Sorry I was late earlier on. I couldn't get out of the kind of the speech engagement, and thanks for coming today. I think it's very welcome that we're having this discussion in relation to the Health Committee. And I think for a lot of us, particularly men, we would have never ever heard of endometriosis. I certainly didn't. I could hardly pronounce the word a number of years ago, but I got a better understanding via kind of that AV presentation 4 years ago, and via friends that I knew that I never knew they had this condition until they spoke up about it. And I've met some really wonderful people in the last few years in relation to advocating for better diagnosis and so forth. Just my first question is in relation to pain management, because obviously with endometriosis there is a significant amount of pain. What kind of is the bespoke kind of pain management path that's people with endometriosis would go? Actually, what pathways do they normally go to for pain management?
There's probably a gap there. I think a lot needs to be done to allow endometriosis patients have holistic care. So pain management specialists as well as dietitians, pelvic floor physiotherapists, along with their consultant surgeon. So I think that's definitely a gap. I think a lot of endometriosis patients won't have the appropriate pain management care.
Yeah, and I think like over the counter doesn't work, and either way, long-term pain management through those sorts of drugs is not how anybody should be expected to live. And you're aware of cases like Amy Brown who've had to go further in terms of accessing the pain relief needed for the extent of her condition through cannabis. So I think it very much depends on the case, but I think what we're trying to say is that the usual prescription is pain meds. Is that really how we want to deal with this, given it spans decades? No, and is there alternative ways to help people manage the pain, I think would be the question. Yeah.
In terms of diagnosis, because has that kind of reduced in time in relation to, because some people are saying, well, facts that it takes years before there's a diagnosis, and is this still the same kind of what's going on?
Not that we're aware of. I think is the.
I think what's happened is that the public are a lot more aware because of endometriosis being mentioned more and more, because we've managed to get it out into the public domain, and they're looking up their symptoms. They're actually presenting to their GP saying, this pain that I've had, these symptoms that I've had, I think it could be endometriosis. Yeah, so there's a delay there, that things like missing school, missing social events, missing family events, they should all be red flags. Yeah. And ideally it should be proactively managed. At the moment, it's very much up to the patient to advocate for themselves, and they should really, it would be so nice if somebody at the age of 14 presented to the GP knowing that their pain wasn't kind of normal pain and was kind of fast-tracked to really effective treatment, to have like the best, say, surgical intervention that they possibly could, so that by the time they're 20, ideally, that could be a distant memory, and they could go on to live their life fully and productively in whatever way they want, instead of always having it with you and having to face multiple surgeries every time the symptoms get worse.
Do you think there's a lack of understanding and knowledge in relation to GPs in relation to this condition?
Absolutely. Yeah.
100%.
And how do you kind of rectify that?
Awareness, education. I think, as Damien mentioned, he's a nurse. He didn't know anything about endometriosis till a few years ago. So all through his training, it never even cropped up.
So like what you said in regards to the male perspective, as and as my colleague here mentioned about the taboo of, menstruation and women's issues, I think we have to have a fair and equitable society. And as Deputy Shortall mentioned as well, if this was a male condition, we'd be hearing a lot more about it.
I think it'd be a very different outcome.
Yeah, exactly. And from my perspective as a male, my voice here is because of my partner and the journey we've gone through. But as I said, as a clinician and a nurse, I just didn't have enough training about it. So that's startling to me, and I think it's not a place to go throwing accusations. But I think we do have to take a look and get the awareness and education at all levels in our health departments, because from a nursing perspective to a clinician to help diagnose, we need to have the proper education, and I think that's probably lacking. And it's just getting that awareness out there as a starting point and educating. It's a travesty that the patient has to be the best advocate for themselves. They're already going through this terrible journey of pain and suffering, and then they have to try and communicate that. They have to nearly be as proficient in the medical jargon as the clinician they're talking to, and then they're not listened to. So that's a frustration, and I've heard that from my own partner. So I guess communicating that now and getting an opportunity for us to be at the table for what I mentioned earlier, like the patient is paramount. So let's get the patient's voice in there, and that resonates with the clinicians, and they say, okay, we've got to listen. We've got to be better listeners. Yeah,
and obviously the knowledge of endometriosis is better I presume the last few years in relation to the medical profession. I'm presuming that, or am I incorrect on that?
No, I was diagnosed 2 years ago because I presented to the GP with my research. It was never mentioned to me in the previous years.
I think I agree with that. I think it's more information is available, so patients have more information that they can empower themselves to get the right diagnosis, rather than the other way around. Yeah.
In terms of surgery, those that have been diagnosed with endometriosis, how many will need surgery?
I think it's hard to say.
Hard to say.
It's hard to say.
And I think that the point is that, surgery isn't the cure.
Yeah, okay.
So it might be a question of how many people will need more than one surgery or multiple surgeries. Is another way to phrase the question.
Yes, I've met some patients who've had in excess of 10 surgeries, which are significant and which can lead to other sequelae, such as adhesions, which then cause further pain. What's also clear is that the disease recurs in a high proportion, maybe in half of cases, the disease certainly recurs. So there's no cure exists.
Yeah. And in terms of speciality, I heard Romania being kind of muted many times. Would many women, outside Ireland go to Romania for surgery?
We understand that they do. Again, with the lack of proper data, it's hard to say. So I think these are the types of things I think we need to understand better, is this sort of information to get, how many really are out there suffering with it, how many do have a genetic link, how many don't, how many require surgery, where do they go? It's all of this sort of valuable information that I think needs to plug into the framework that's being developed. And if I might use this opportunity, because I think we spoke about the framework in terms of what we were looking for in terms of education, diagnosis, treatment and research. And I think one of the areas you mentioned, which I think makes me think that we haven't covered it in sufficient detail, is the pain management. In that, the way it's traditionally been treated isn't effective, and nor would we want to say just long-term stay on over-the-counter pain medication. That's really not the solution. And to look at feeding that into the framework, because it is a really important piece of it. There's some that, have had the surgery and maybe still need the pain management on a daily basis. And I'll come back to Amy Brown again in terms of what she's had to do by herself in advocating for change to get what she needs, that I think it's important that we encompass everything when we're looking at that framework.
Yeah. And obviously when we're talking about pain management over the counter, we're talking about codeine and poppy in the prescription form, opioids.
Yeah.
And obviously in the long term, they're not good.
No, absolutely not.
Absolutely not.
That's why it needs to be explored, and I think that, we're not really at a place or a juncture where we can actually rule stuff in or out. We have to explore the options. People are suffering, they're in pain, so we need to give them what's going to put that pain at ease. But at the same time, we need to be understanding that there is consequences to that. So we're not blindly just saying, here, go be on a long-term prescription on an opioid. So I think we are not supporting that enough. There needs to be dedicated pain specialists with this particular pain in mind, because pain is individualized. So that's something that we do need to have an extra focus, like Alana mentioned there.
Just my final question is in relation to the framework. Obviously, there's been a kind of, it's been welcomed, but there's obviously a level of criticism in relation to it's been treated at primary care. How can we kind of make it better? I mean, I'm probably stating the obvious question, but how can we make it better for what we have, what the Minister has announced in relation to this new framework?
I think it just completely underestimates the disease. I think there's very few cases that can be dealt with at primary care level, and as we've already mentioned, it speaks to GPs having a presumed diagnosis. That is not happening at the moment. So at the very first hurdle, I think we face issues. It's not being seen, and for diagnosis, you need the laparoscopic surgery, and you need to remove the disease is the best treatment. So I would say the majority of cases need to be referred on further. Yeah, definitely.
And following on from that as well, there seems to be a reluctance to go forward with diagnostic surgery, which is quite strange, seeing as it's the only way that you can get the histology samples to confirm the endometriosis. And it's not as if one would just have a surgery for the purpose of diagnosis. No surgeon would do that. It would be unethical. That it would also be surgery to treat and to try and remove as much of the endometriosis at the same time. So it's kind of...
I think in terms of imaging technology, I think, it is improving. It definitely, the disease can be missed, and I can speak to that myself in terms of an MRI not showing it when it is there. So maybe it's more training in terms of imaging technology, more development there, or more facilities at primary care level to be able to do more than just talk about people's symptoms. Because, as we said, the laparoscopy is the gold standard, but it is an invasive procedure.
What would say that word again?
Laparoscopy.
What would that be?
It's done under general anaesthetic. It's invasive. It goes. I'm not medical. I had it done, but I was knocked out, so I don't know what happened.
So keyhole surgery, essentially, and as what Alana mentioned there, from the perspective of primary care centres that tie into Sláinte Care again, that what does that entail? Do we have the relevant diagnostics in terms of medical imaging, and the people well trained and equipped to spot the signs there, so that they can maybe prevent having even to go for, while it is minimally invasive, just to avoid that step. But I think having the skill set to identify it on medical imaging would be excellent. But as I mentioned again, having that conversation and talking to the patient advocates to understand what would be the gold standard, I think that's what's missing from the framework, for example. So there's definitely lots of solutions which we'd welcome working with anybody putting those next steps, because I guess we identified that the framework is just that. There's more stuff to be elaborated on and developed.
I might come back later on.
Okay, no problem.